to higher successful rate for AP-ROP or zone 1 ROP. And it's good for cases with tunica vasculosa lentis or the patient with unstable systemic condition. And it was reported to result in less refracted errors. For example, this is a case of AP-ROP. Following the treatment of Avastin, the retinal vascularization continued towards the periphery. And this is an example of prominent tunica vasculosa lentis. In these cases, pupil could not be well dilated, and but following the use of Aflibercept, and you could see the tunica vasculosa lentis disappear within a day or two, then the pupil could be well dilated, then you could have better assessment of the fundus. And our prior study also has shown that comparing to laser or cryotherapy, anti-VEGF treated eye has less refracted errors. However, there are also some concern about using anti-VEGF for ROP, such as slow retinal vascularization, late recurrences, ocular inflammation and infection, and systemic adverse events. This is an example of late recurrences following the use of anti-VEGF for ROP. The recurrences occur at postmetrial age, 69 weeks following the at recurrences. So it's almost 10 months after the initial treatments. So if you use anti-VEGF for ROP, definitely you need to monitor this kid closely. And in Mean-Hitner's paper, they also found about 7% of the eye would have recurrences, and the peak time of recurrences around 45 to 55 weeks postmetrial age. So I think the key message is close and long-term follow-up is necessary in patient following after anti-VEGF treatments. And another big concern is the long-term neurodevelopmental outcome following the use of anti-VEGF. And because all these drugs would circulate to systemic circulation following intravitreal injection, and these drugs would cause systemic circulation, systemic VEGF suppression up to 3 months because of this. And because VEGF is important neurogrowth factor, we don't know whether this suppression will cause the long-term detrimental effect on the neurodevelopmental outcome or not. And recently, we did a prospective study on these kids following the use of Avastin treatments. And we follow these kids in average 2 years old. We look at the neurodevelopmental outcome by Bailey 3 evaluation system. And in the cognitive score, we found that there were significant differences among 3 groups. This group 0 was the patient who had prematurity but without ROP. Group 1 was a patient who had ROP but without treatment. And group 2 is a patient who has ROP and with Avastin treatment. We found out that there were significant difference among 3 groups. However, if you look at group 1 and group 2, there was no significant differences. In the language score, there was no significant differences among 3 treatment groups. And in the motor score, there was significant differences in the gross motor scale score among 3 groups. However, again, if you look at the group 1 and group 2, the patient without treatment and the patient with Avastin treatment, there was no significant differences. So the other even more important issue is the long-term outcome. Whether after 5 years or 6 years of treatment, what are their long-term outcome compared to laser treatment? So recently we published a paper and we compared the 5 years outcome between laser and Avastin. We found that compared to laser-treated eye, these Avastin-treated eye has deeper anterior chamber, and they have more fovea depression, and they have thinner macula thickness, and they also were found to have better bare vision because they have less refracted error, but there was no significant differences in their best corrected visions. So in conclusion, I would say with proper follow-up, anti-VEGF use for ROP may result in better anatomic and functional outcome in the long run. And finally, I would like to say that if I have ROP kids myself needing treatment, I would use anti-VEGF for them, and I would have close monitoring of their outcome. Thanks for your attention.
Thank you, Wu. Now, Tapas is going to be opposing the issue here. So
very good morning, and thanks for giving me an opportunity to share a few of the cons on ROP use of bevacizumab in every case of ROP. Now, first of all, there are reports are many who tell that no, definitely the injected bevacizumab affects the course of retinal vascularization in the eye, as we see one of the paper where we see that the abnormal shunts, anomalous circumferential blood vessels, and persistent retinal avascularity. Now, among all these changes, the one that worries me most is the marked deceleration in the anterior-posterior vascularization in these cases. As we can see here, it is now 54 weeks of postmenstrual age, but the vascularization is still in the zone 2 posterior and leaving behind lots of avascular retina which can secrete VEGF and cause recurrence at any time. Now, these eyes behave differently, and probably the anti-VEGF converts for the eye from a ROP phenotype to a FEVR phenotype to a certain extent. Now, examining these babies when they grow up, say 1 year, 1.5 years, doing a good peripheral examination is really challenging, and all of us know this. Now, the time and pattern of recurrence also is unpredictable. Sometimes you can see, as is shown here, this baby received Avastin because of NVI and poorly dilating people. The eye was doing well with a smoldering coarse abnormal shunt, but all of a sudden thick pre-retinal hemorrhages overlying the shunt that persisted for another 6 weeks and regressed only after leisure. Now, issues related to persistent avascular retina, the eyes remain avascular. Studies by Lipor, Tahija, many others have shown that not only the peripheral retina remains avascular in some, but also the posterior pole, the foveal development also gets affected. And these avascular retina, when they come up in a later part of life, lead to lattices, retinal breaks, and sometimes retinal detachment. As we can see here now, you will decide like this baby who had aggressive posterior ROP, laser was done in the right eye, but at the end of that eye, this child became unstable, and we had to inject in the other eye because of poor vitals. And we can see here that within a matter of 2 weeks, the eye is regressed, and it's once done, finite follow-up, and that's all. In contrast, in the left eye that was injected, we can see that the eye underwent a smoldering course, and we can see still large anomalous circumferential blood vessels shown here, and avascular retina even at 52 weeks. So yes, there are ocular complications too that might not bother you in an adult eye, but they can have significant influence when in an infant eye. As we can see here, the most important is progressing cataract. In adult you can operate, but in the child we have injected, and in case you land up with cataract that progresses, then we don't have an opportunity to examine and look for the recurrence, and also we can't laser it off. Then we are in trouble, and operating this in individuals to make the axis free of opacity also becomes difficult. The endophthalmitis, the dreaded complication, this was the baby who was injected elsewhere and came to us at a time when both the eyes are thusical. Now, this might be 1 in 500 or 1,000 or 10,000, but who knows, this may be your first case, this may be your 10th case. So one need to take care of this. Now, we know that bevacizumab, they help a lot in decreasing the vascularization and reducing the incidence of hemorrhage on table when we operate. But if we don't, in case due to some reason like here, after injection, if there is a delay to certain extent by 2 weeks or something, now you can see that the funnel is closed and you have lost the opportunity. So These are the few issues. Among the systemic issues, we all know that the bevacizumab injected inside the eye definitely reaches in systemic, in a significant level that suppresses the VEGF for almost 2 months. And among all these things, the issue that worries me is the long maturation. And like many other reports, the 4 out of 39 babies injected, the major cause of death is the long-related issues that we need to keep. Now, there was no consensus on the dose. The body of an infant is 1/50th, and the half-adult dose, some reports say that this provides 1,000 times more antibodies than the VEGF concentration in an eye. So are we justified in following the dose in a guess? So finally, anti-VEGFs in ROP is definitely promising an extra therapeutic option, but we need to think of the ideal dose, possibility of overdosing and systemic side effects, long-term smoldering course, examining the baby and assessing a good follow-up, compliance for follow-up and complication of invasive procedure. These are the reasons why we keep it as reserve drug, not for primarily use in ROP, and judicious use in selected cases is our way. Thank you.
Thank you, Tapas. We need somebody to just tell everyone how to vote. I think, who's the person here who's going to give instruction? How are people going to vote? No, not you. Somebody, I think some person who's we have to give instruction also what they have to press. I mean, somebody should be, yeah. So what do you press here? What I've been conveyed that if it is A, it is pro, and if it is B, then it is cons. So you press either of either of them. I think then we are fine. No? Yeah, just a minute. I think they're to either of the speakers. Okay. Well, I think this is the most burning topic. We need so much of time as far as anti-VEGF and ROP are concerned. So we're going to have always two opinions about it. I think I tend to agree with both the sides, but the question remains at this time, especially in country like ours, where there could be a big misuse, and which is happening, in fact. For very mild ROP, people are giving injections because that is the easiest way. Who would like to break the neck and do the laser, and then you need more expertise? So that's where the biggest worry for us is, and we have even seen in my own setup there, where they have given not one but 2 injections. And in such a situation, we are following some of these children now, those who have grown up. The retina is not getting vascularized beyond a point at all. So there are many issues. And of course, it's a wonderful drug. I think let's start with the voting. I think...
yeah, can I add one thing? I think when you use anti-VEGF, definitely follow-up of these kids are crucial. And because in our scenario in Taiwan is a small country, so and access to the medical service is very good. So the patients' follow-up is very good as well. So we have confidence if there's anything happening following the use of anti-VEGF, you can deal with it. So there's a window that you can handle these complications such as crunch phenomenon. But if you are not sure you can follow up these kids adequately, I would definitely think laser might be a good choice.
Thank you, Wu. So everybody already voted. So we have, no, this is just a sort of equivocal kind of thing here, where we are not reaching anywhere. So, well, that's what it is. Thank you very much.
Sir. we ask for the vote for those of you who use anti-VEGF as a primary treatment of choice versus those who would use laser as a first treatment of choice, then I guess there's more clarity of thought, because most of us know there is a value of both. But the question is that what is your practice? That is, a patient walks into your clinic with ROP requiring treatment. What would you choose as a first treatment of choice, provided both are possible? Laser as well as injection is possible. I'm not talking about eyes with non-dilating pupils, you're not able to see the fundus properly, and you want to inject anti-VEGF. Well, everybody will inject it there. But I'm talking about where both are feasible. What would be your option currently? That's where probably there will be more clarity.
I think let's go with that. So what is your primary treatment? If we take that, let's vote again. Is your primary treatment laser or anti-VEGF? So for primary treatment, laser is A, and B is for the primary treatment is anti-VEGF. So you can again, we can start voting. Is it okay? Yes, vote. No, A is laser and B is anti-VEGF. So perhaps I think that's the way it is. Primary treatment at this time, whatever we have gone across in many countries, very few are using as a primary therapy. Wherever you can laser, you would. Maybe where we are using, I mean, already even Wu said zone 1 ROP or AP ROP, where the need is there and we require something more, and the laser may fail in many situations. So thank you very much. Let's move on.
Thank you, sir. Very good morning to everyone. We'll go to the next one, that is intraoperative OCT improves outcomes. Srinivas Joshi is already here. Can I have Dr. MeenaChakraborty on this side, please, ma'am?
One and all, thank you, Scientific Committee Chairman Vishali Madam, for giving me this talk. So let's see about the intraop OCT. It's the two standard technology, that's the OPMI Lumira 700 with the OCT system, where you can have 1 line, 5 line, crosshair, cube scan. Any number of scans can be acquired with a high speed of 27,000 A scans per second. I'll not go into the much details. These are the various applications of the intraop OCT. And however, now we also have an extended indication. So let's run in through a few of the examples of the intraop OCT. See here, this is the case of vitreomacular traction. The patient is highly demanding patient with a 6/9 vision. He was complaining of metamorphopsia. Then we thought, okay, let's get rid of this the vitreomacular traction. So I just put an IVTA to stain it, and then induced posterior vitreous detachment. Completed the vitrectomy. Here you can still see the hump. And it is so thin that any surgeon would be worried whether it would cause de-roofing in this procedure. So I just stained it, and as I keep on peeling it, now you can see how the ILM rolls over that peak point without causing any de-roofing. You know, this gives a kind of confidence for the surgeon. Yes, I have not created a macular hole in this patient, and I'm not going to use any gas in this patient or positioning in this patient. So that's the kind of confidence, and which will help us in the post-operative counseling for the patient as well. Then did a fluid air exchange, and then just completed surgery. So this is another technology. Who wouldn't like to have this kind of technology? See, overlay, like how you do, and the radiologists do a guided kind of procedure interventions. Now you have the overlay of these procedures right on the top of the screen. So that gives an added advantage to the surgeon. And here I'm just trying to do a modified inverted ILM peel technique. And then you can see on the table, you can see the closure of the macular hole. So this is again, which imparts confidence in the part of the doctor, and which helps us to, counsel our patients much better. And the success rate in these cases are more useful because what you see on table is definite, rather than waiting and expect the results to be on your side post-operatively. See here, the post-operative photograph shows the large macular hole, type 1 closure. The patient improved from 660 to 618. So let's look into some of the few other indications, like in case of membranes or diabetic membranes. So it's not playing. Yeah. So once I remove this, see here. So nicely you can see the bridging of these membranes. So underneath you can put your cutters and try to cut these membranes, do a cutter segmentation, conformal segmentation, or fold back delamination, whatever you want. See, so nicely it gives you a guidance where to introduce your cutter so that you don't want to have an iatrogenic retinal breaks in this case. So these are the another added advantages where it also helps. Not only that, when I placed my intraop OCT on the macula, I could see a macular hole in this patient as well. So these are some of the surprises which we get intraoperatively. Then I did a ILM peeling in this technique, and you can see the macular hole here. Yeah. So I did a ILM peel in this technique, and the patient is really happy. So these are another set of cases where you can see some of the, again, surprises, like I just found a large blood clot here, and I just wanted to know at what level is this bleed. So here again, intraop OCT comes to your rescue to see that, this the sub-ILM bleed, what needs to be done, whether ILM needs to be peeled or not peeled. So here what I did was I did an ILM peeling where intraop OCT helped me in doing such procedures. And finally, I tried to dislodge this clot, but this clot was very adherent. So I didn't want it to, make an iatrogenic breaks here in the retina. So I just did a fluid air exchange after doing ILM peeling, and post-operatively you can see the clearing of the blood clot very well. So there are various studies, like Discover study has been done, the Pioneer study has been done, which shows that 48% of lamellar keratoplasties, the intraop OCT was useful, and 43% of the membrane peeling procedures, intraop OCT was useful. We did our own study, a pilot study of 62 patients, and we did a pre-op where pre-op OCT was not available because of the vitreous hemorrhage. In these cases, when we looked into the surgeon's feedback, grade 1 was not useful or obvious, useful for confirming the diagnosis but no change in the intervention, and grade 3 is very useful, altered or added as surgical intervention. And lastly, I would like to say in this study that intraop OCT altered or changed the management in nearly 39% of the patients and confirming the clinical findings in 32. So it was totally useful in nearly 71% of our cases of the pilot study, and the surgeon grading shows that the mean IOCT time was just 2.46 minutes. So can't you spare just 2.46 minutes to your patient to have an improved visual outcome? The rest is left to you. Sab kuch dikhta hai. That's what is said. So if you treat what you see. I would like to end this debate. Thank you very much for the patient listening.
Good morning, ladies and gentlemen. I am the debater from the con position. Can I have my slides on, please? Before I start, I would like to stake my claim that intraop OCT does not improve functional or anatomic outcomes in our patients. I don't use an intraop OCT. Now let me put before you the evidence. What percentage of our surgical VR cases would you require this white elephant? I have divided the surgical VR that we usually do into 3 categories. The first and the second are what we do usually, where we do get some additional information, but at what expense. The third, when intraop OCT is absolutely vital, especially if your surgical practice deals mainly with subretinal surgery, which I don't use, which I don't do. So this brings to my mind this quoting by Will Rogers, that too many people spend money that we have not earned. Just think about a hefty loan, the EMI and the interest rates that you have to pay to buy things that you don't need in its present state of evolution. That does not mean that you cut corners when you're practicing. I don't practice with an operating loop. I use a high-end microscope with a wide-angle viewing system to improve visual outcomes in my patients, but I do look at the logistics. My slide is not moving forward.
because it says that you need to have a high-end technology.
So if you look at the routine VR, bread and butter practice, where the macular surgeries, where the intraop OCT does bring in some useful information, and to prognosticate to a patient that visual improvement is likely to occur or not occur, do we prognosticate on the table to your patient or later in your consulting room sitting across a table? Because sophisticated analysis of the intraoperative data with a 4D real-time microscope integrated OCT is feasible only post-operatively. So do you still want a during peel or first post-peel OCT, or are you willing to wait for the first post-op day OCT without an additional cost to your patient? This is an OCT to show that even the NFAS microscope view does show us the macro architectural changes that occur in the retina, and these are the post-peel OCTs on the 1st, 7th, and 14th post-operative day. A full conventional NFAS retinal view is much larger than what is seen in the volumetric scan, so you're able to perform better, your surgery is much better. Identifying tissue planes depends upon the tactile feel that the surgeon has on the table. It is something which has to be learned with experience and cannot be learned with an intraop OCT. Instrument visualization is another thing which has been hyped about. But just think about the instrument void, which is different from the endo-illuminator shadow that you see. This is a shadow again cast by the instrument in the OCT frame. It is visualized posterior to the tip of the instrument. And are all instruments visualized during the surgical maneuvers? No. You have to upgrade your instruments to matte, brush metal, or polymers. You can see the Finicity flex loop, the Tano scraper, and the Pinnacle ILM forceps, but you will not be able to see the Constellation cutter. We do majority of our membrane surgery with the 25 or the 27 gauge cutter. You cannot see the tip of the cutter with the OCT. Does microscope integrated OCT replace ERM and ILM staining, reduce surgical time, and reduce toxicity? No. In the present stage of evolution, it does not replace ILM staining and peeling. And if you have a SD-OCT, then the use of ICG, and you use ICG for staining, then the pooled ICG, you cannot see the tissues below the pooled ICT with the SD-OCT, but you can with the SS-OCT. This is straight from the horse's mouth. Instrument visualization and peeling maneuvers are visualized in between 50 to 100% of the patients, and only for macular surgeries. And when your field of view or your surgical field of activity is eccentric, you have to repeatedly keep on recentering your OCT scans so that you can get an image. This tactile feel in doing a PDR surgery and identifying the tissue planes comes with surgical appearances in unimanual surgery without an intraoperative OCT, where the membrane is peeled easily by identifying the tissue planes and the vascular nails that are present. You don't need an intraop OCT at very high cost in your surgical armamentarium to manage a case like this. And does MIOCT prevent recurrence? This is the results of the Pioneer study, which shows a recurrence rate of 2.6% and 1% of these patients needed resurgery. In my own practice, the recurrence rate without intraoperative OCT is very, very minimal, and I have not had to do resurgery in any of these patients. 9% of the patients, the IOCT confirmed membrane removal, and additional maneuvers were prevented. So after having upgraded your microscope, purchased the intraoperative OCT, upgraded your instruments for a very minimal improvement in your surgical outcome, does it fit your practice? We are catering to the masses. We need more standardized VR surgeries, VR centers in our country, and not intraoperative OCT. It's up to you, ladies and gentlemen, to give your decision. I thank you very much for your patient hearing.
Yes,
I think, okay, Dr. Atul, please.
Not that I'm in favor of any particular thing or against it, just as a neutral speaker I'm saying. I've been using IOCT at the RP center, and lately doing a lot of submacular bleeds due to PCV, because we're getting patients, despite anti-VEGFs, they bleed. So I inject submacular TPA, but these people also, these eyes also have PDs, multiple PDs. So to locate where the subretinal submacular bleed is, and my needle goes into the submacular space, because I inject submacular TPA, versus injecting into the PD, so that I have to avoid. So I choose an area based on the IOCT guidance. Also, closure of the holes, when my inverted flaps come on, I make sure that with the IOCT guidance, I can see the flaps lying on the defect. So I find it sometimes of use, not always, sometimes.
It is definitely useful if your VR practice consists mainly of complicated surgeries, such as the submacular surgeries, subretinal processes,
Ma'am, all of
subretinal
us do
therapeutics.
such surgeries. I think all of us do the surgeries. Otherwise, we won't be called retina surgeons if we don't do these surgeries.
I think...
Sir, do we have 30 seconds for rebuttal? No?
Well, I think let's go for the voting because I think we're a little bit running out of time. How should we vote here? How many feel that it should be the essential part of your VR surgery armamentarium? And so I think we'll vote that way. And how many feel that it may not be, that you can't work without it? So let's vote A and B.
A is for if you have
essential.
a funding. If you have a funding,
Yeah.
and you want to buy it, if you have a funding, of course. So it's me and Atul sir only.
So thank you very much.
much.
I think we had a very interesting debate, and these are some of the technologies. I think if we going to have money, we should have that. And with this, we move on to the next one. And next is Heads Up 3D PPV, Professor Atul Kumar, and of course, Dr. Muralidhar is here. Oh, NS, yeah, okay, sorry.
So, thank you, Professor Dogra, and thank you, VRSI, for inviting me and as a speaker. So, I'm speaking on Pro for the motion for heads-up 3D viewing for VR surgery. It's not actually PPV, it's for viewing. It's a viewing device. So, what do we understand? What is this thing which has just caused some, disruptive technology to come in? This is heads-up. Is basically that you look straight at a screen, which is a 3D screen, and it's a digitally assisted VR surgery, which is giving you an enhanced digital zoom. So this new device is actually a three-dimensional camera, which is fitted in place of your oculars. What you look through is your oculars. Instead of the oculars, you have a camera, high definition camera over there. So you just have the microscope in front of you to look into the retina. But you have a hand-eye coordination because you're looking at a screen. And through the camera, the relay goes to the OLED screen, which is a 4K OLED screen, which you can see on the left, on your right. And this is a screen which even has the IOCT display with it. So you can do the surgery as well as see the IOCT. And this is, you use passive Polaroid glasses, not the active ones. And you have assistants and your residents, because I work in a teaching hospital in Delhi, and we have a lot of residents, as Professor Dogra has, and we both feel that we should have devices where we can teach our residents, and I'm specifically being very keen on teaching. Whatever I do, I like to share it among my residents, and they really feel satisfied. We can ask questions during the surgery. The image quality and stereo acuity is definitely higher. You get depth, very good depth, and very good magnification and high resolution. And digital technology, I feel it outperforms the classic microscope eyepiece-based technology, which I also do. So not that I've shifted totally, but it's just that I like to do both. And this is showing a small video clip, very short video clip. This is a patient who had a recurrent detachment. He had fine submental bands in the inferior quadrant, one of which I felt was going to hinder the success of the surgery. So you can see using the digital zoom, how much magnification I've got. I can see each and every membrane very clearly. So I chose the membrane where I wanted to pick up the subretinal membrane with the forceps. And When I pick it up, I break the membrane, and once it's broken, the traction on that membrane gets released. And so this helps me a lot. So this was a case of failed detachment, which I did. The contrast and color saturation can be altered. This cannot be altered in the classic analog microscope, which you look through an eyepiece. So I can shift my shift to yellow color, which I often do, to see the ILM and the surface of the retina very nicely. It has a luminance that is much less. What light you use with your endo light and your microscope light, the endo light especially you can reduce. So the risk of phototoxicity, about which Professor Dogra has talked a lot in the past, is very dangerous. The microscope phototoxicity as well as the operating light microscope light pipe phototoxicity is much less, because the light you use is much less. With the 3D system, the Ingenuity 3D system, I have no financial interest in this anyways. So it's just that you have less chances of phototoxicity, especially for macular surgeries. Now looking through analog microscope, even if you're looking straight on, you still have to crane your neck a little bit, and you've got to stiffen your muscles, especially your back muscles, despite the best of exercises you do. But when you're looking at the screen, you're really looking at a huge screen and a very high magnification. This helps. There's less asynopia because you don't need to accommodate. So this is a case where, again, I want to see you, I'm showing you 2D pictures because unfortunately we need a 3D projector and 3D screen, which we don't have here. So this is a case of very advanced siderosis who had this pigmentary changes with the rhegmatogenous detachment and the macular hole. We took a chance thinking that we'll be able to do something for the patient. So you can see the kind of resolution you can get with, this is seeing it on the screen. And when you see it on the screen, you can see that there's a foreign body which is actually getting ionized. The ferrous foreign body is getting ionized, but you can see the periphery very well. This is one thing I've noticed. So many of my surgeries I've shifted about 70%, 80% to the Ingenuity system, just like we shifted to the 23, 25, 27. So I like to use a bimanual approach for these kind of impacted foreign bodies with the chandelier. So you can see the kind of magnification you can get. You're literally sitting with the foreign body. And the magnification and the depth is so good that this particular video I just bought along, I thought I'll show a small clip of this, the handshake technique, and bringing the foreign body at long axis with the forceps. So it's finishing and the time is over. I just want to say that this is the advantages. Thank you so much.
Thank you, Professor Atul. And now we go on to Dr. N.S. Muralidhar.
Thank you, Chairman and friends. I thank Dr. Vishali Gupta for giving me the opportunity to be part of this debate. Let me tell you, I had the opportunity to use this for a short time in our institute. And, well, do I want all of you to buy it? I don't think so. In my last 35 years of my professional life, I have seen some major advances in ophthalmology. I started off as an intracapsular cataract surgeon. Then we started doing extracapsular cataract surgery. Then extracapsular surgery gave rise to SICS to phaco. And then when I stopped doing cataract surgeries, I know I'm doing vitrectomies from 20 gauge to MIVS. These were all major advances, real advances that made a lot of difference to the outcome in the patients that we manage every day. But some of the advances that are touted today, you always say, really? Is it an advance? Like phaco to femtosecond laser-assisted cataract surgery. What's the big difference to the patient? Nil. 25 gauge to 27 gauge. So what? The results are same. Similarly, microscopes, surgery to heads-up 3D surgery. I don't think it makes a great difference in the long run or to the patient. Before you embrace any advance in technology, the technology or whatever is the intervention should show a documented benefit to the final outcome to the patient. Till date, I do not have any evidence today that surgery done with Ingenuity or any other 3D system, heads-up system, gives better results to your patient than done with the microscope. I know Atul is a fantastic surgeon. I know the surgeries that you used to do before and the surgeries you do now are the same. The patient outcomes are same. So ultimately, to the patient, it doesn't make any difference. So finally, who is going to bear the cost? Ultimately, whatever you buy, whatever equipment you buy, the patient has to bear the cost. How can you justify this cost to the patient when it does not result in an improved benefit to the patient? And ultimately, I don't want you to end up buying an expensive toy that burns a hole in your pocket. So be careful. So the minor irritants, it's not, everything is not rosy. Remember that this is a large screen, TV screen that occupies space in your OT. Or we are always fighting for space in our setups. You know, these OTs are all small, we want to have more space. You may have to reorganize your OT. It may be so difficult to put in this extra space. You need special glasses. Everybody needs to wear glasses. When the glasses are interchanged and used, there may be a spread of infection. I believe in an institute, there was a spread of conjunctivitis because of this. Assistant and the scrub surgeon needs to turn. The surgeon is looking straight, but what about the assistant? He is not looking into his scope. He has also turned his head. Scrub nurse turns the head, and that also the room needs to be in the dark. So where is the ergonomics if the assistant has to turn and look at the screen all the time? Sometimes in the dark room, the scrub nurse may find it difficult to give you the proper instrument, and she may hand over a wrong solution to you. And the first time when this was assembled and then it was seen on the screen, the technician, the engineer who had come said, "Why is the image not so good?" He said, "No, your lenses have a little scratch. That's why this image is not good. We have been operating with the same lens for the last 5 years." He said, "You have to change the lens." I said, "I'm sorry, I can't do it. It costs 1.5 lakh rupees. So we still managed to operate with the same lens. So that means this also magnifies the media opacities and the defects in your lens. The angle at which you view makes a lot of difference. You need to adjust white balance every time the system is switched on, otherwise it will just shut down. And the inverter is done with a keyboard, not with your microscope, not with your foot pedal, so you're dependent on an unscrubbed assistant to do it. Ergonomics, whenever I sit and start my surgery, I make sure that the oculars are placed in such a way that my back is straight. And once it is set throughout the surgery, my back remains straight. But here, you're just sitting and looking at the screen. You don't know how your posture is. You're not going to give attention to the posture. You're going to look at the screen and do the surgery. So I might end up with a bad posture more with the heads-up surgery than with the microscope surgery. So in conclusion, ladies and gentlemen, this is an equipment that needs heavy, heavy investment, burns a hole in your pocket. Till date, there is no documented better outcome that surgery with the 3D system gives you better results than the standard microscope surgery. Therefore, I argue that the added cost does not really justify the benefit that your patient enjoys. And I'm a little wary of becoming technology dependent. You know, what if the glitches come? You cannot call the person over the phone and then he cannot come and set it right. Then you may have to stop in between and switch over to a microscope surgery if you have a major clip. And remember how that's going to be in your practice. And always remember, this is an evolving technology. So tomorrow, if somebody comes out with a better system at a cheaper, price, maybe you will be better off. So please wait till such time as this technology is affordable to all of you and shows better results than the standard microscopic surgery. Thank you.
It goes, I'm reminded of long time hands used to be shown, ECC versus phaco. Nobody would vote for phaco because it was expensive. Everybody said we get same results. Only thing is maybe difference of some weeks. And then I'm reminded of 20 gauge versus what we have now, the system where we have gone, I don't say sutureless, we do put sutures, but then that's, what is the big deal? We've been doing 20 gauge, we don't need extra money, we get same results. Perhaps we changed. So what I would say, is it, if we vote it like this, is it a technology which may be a future, or you feel it's not? So if it is a future, then A. If you feel no, it's not going to be future, then B. Let's go for voting.
So it's not clear, sir. What's the voting for?
Voting is whether it is a technology of
it's for future, not now.
Yeah,
not now.
Yes, yes.
Thank you.
I think we are there at the transition phase, so thank you very much, friends.
So we'll go to the next one. Again, another expensive tool, OCT angio versus as a must for clinical decision making. We have Dr. Mahesh, Gopalakrishnan, and Dr. VR Saravanan.
Good morning, friends. I am talking for OCTA, which is must for clinical decision making based on my limited clinical experience of OCTA for the past 1 year. I will give some practical cases. This was a case of defective vision of left eye, visual acuity 3/60, some hemorrhages are there, creatinine is quite high, I can't do an angio, and OCT shows drill, thin retina, but OCTA is beautifully showing the ischemic macula. So this is the cause for defective vision. Many cases of tributary vein occlusion, we can get rid of fluorescein angiogram and find the ischemic macula by this OCTA. Case 2 has been, the patient had treatment with PDT and multiple intravitreal injection for something like chronic CSR, and this is the picture, fluid, subretinal fluid at the macula, pachyvessels, and OCTA shows a network in that area. So this pachychoroid neovasculopathy, the OCTA is very useful even if fluorescein angiogram is non-specific. Case 3, myopic CNVM. All of us know that to delineate myopic CNVM, you need fluorescein angiography. OCT may not show the activity. So this case had a defective vision of right eye, and this is the OCT, recent metamorphopsia. So you can see pre-RP hyperreflective complex, and this is the OCT picture. And fluorescein angiogram definitely shows the leakage with fuzzy margins in the late phase. And after injection, you can see the resolution. But do you need a fluorescein angiogram? You just see the OCTA, beautiful network is seen pre-treatment and post-treatment. And in fact, even if the OCT is dry, some of the network can be seen in OCTA. So the patient may be requiring additional injections after the initial 1 dose. Case 4, unexplained visual loss in diabetes. It has been the dictum that indication for FFA, one of the indications is unexplained visual loss in diabetic retinopathy, in diabetes. But here, many cases we come across where we can't do fluorescein angiography due to nephropathy, contrast cannot be done, or a sick patient with multiple systemic ailments. Just, this is the OCT, spongiform edema, drill, and you can beautifully see the superficial and deep vascular network showing the ischemia. So there also we can get rid of fluorescein angiogram by OCTA. Then this is another case of CNVM. The patient was on treatment for the left eye where the multiple injections and PDT. This is the left eye with spongiform edema, ellipsoid loss. Right eye is reasonably normal with a small double layer sign. This is autofluorescence. Right eye also shows some changes, but left eye, the central area is involved. This is the picture of fluorescein ICG. There is RP window defects and staining, but nothing specific in the right eye. Left eye shows staining just next to the fovea. And this is the right eye post-treatment, pre and post-treatment. But surprisingly, in the left eye, there was a network which we have been calling non-exudative CNVM. This is in the right eye, which was not affected. So this may be one of the reasons for keeping him under close follow-up, because he may develop treatment. Ultimately, what are we aiming at? We are aiming at giving the patient good care, early detection with better outcome. So these are some of the current uses which I found very useful in use with OCTA. Ischemic maculopathy, PCN, non-exudative CNVM, myopic CNVM, and where you cannot do a dye angiography. Hope you had, all of you had nice anaphylaxis with fluorescein angiogram, and you will be remembering those cases with terror only. So this is one case which can replace many of these cases. So anything new, we have the habit of protesting against it. It is not for us. It is expensive. It is that. This is, so even we protested against computerization once upon a time. So I can't tell that you need to go to the hospital only in this vehicle. You can't use this vehicle. So, but probably I can rephrase it. OCTA a must for clinical decision making by OCTA a very useful adjunctive tool for clinical decision making. And after a few years with refinement of technology, OCTA will definitely be an absolutely essential tool in multimodal imaging. Thank you.
Can I have a slide? So by showing the last slide, I think already...
Can we complete the debate and then after that take the questions?
I think already Mahesh has given up by showing the last slide. Can I have the slides, please?
have the slides?
Okay, thank you. So thing is, we've been all these years since the first, always first described fluorescent angiogram, we've always been oriented towards leakage. We've been used to seeing leakage in any aneurysms or leakage from the choroid, neurocell everywhere. And suddenly you say you're not going to see leakage, you'll be just seeing like NVD in the left side, and if you can say right, compared with the FFA of OCT and FFA. Thing is, like it's saying, like I've been eating idli sambar and dosa for all these years, suddenly they can eat only sandwich and ham. So I'll die. I mean, it's not possible. So thing is, all these new technologies now recently they've been talking about seeing wide field imaging, like seeing from periphery to periphery, aura to aura, or equator to equator. All this has been new thing. And even in angiograms also, suppose I have to do a peripheral imaging using a OCT angiogram, I have to take so many cuts and then try to fuse them. And it takes such a long time. By the time I finish one eye, it will take almost like 2 hours for me to, especially in a slightly not very cooperative patient, to get a wide field OCT angiogram is very, very difficult and very, very time consuming. Whereas with the newer angiogram, FFAs, with just 1 second, I can take a very nice picture from aura to aura, and again, I can see all my leakage right sitting there, guiding me how to go about treating these patients. And especially in OCT angiogram, if the patient is a little bit uncooperative, if there are media haziness, the quality of the image degrades so much that it's unusable. So that is one big disappointing thing. And talking about some of the case examples which Dr. Mahesh showed, in PCV, yes, we have always been seeing these typical BVN and the polyps we are in very good ICG angiograms. But when you see OCT angiograms, the polyps are not picked up early. Like compare the one of my cases with the OCTA in the left eye and the ICG in the right eye, you can see the BVN and the polyp very nicely. But here if you see, depending on which cut you take, sometimes the BVN is less small or big, and obviously the polyps are not very easily seen, which is a big disadvantage using OCTA. Only you tend to see the large polyps. And because all occult membranes are picked up in OCTA, we don't know whether it's a pachychoroid neovasculopathy, whether it's a occult CNVM, whether it's a BVN in a PCV.